First, I'd like to say thank you, Dr. Morante, for helping me pass the ANCC exam. I did take the Flex crash course, I did the question banks, and the one-on-one was super helpful, especially with the fast facts that were provided. I'd like to thank you, Dr. Morante, for being such a supportive preceptor and mentor throughout my process. Your knowledge and experience and compassion are top-notch, and I'd recommend you to anybody. So again, Dr. Morante, thank you so much for being so supportive, and I am thankful that you were my preceptor, and the classes that you provided were very informative and really helped me to pass the test. So I just wanted to say thank you.
Thank you to Dr. Morante for always being my cheerleader. His live review class was very informative, and the Q banks were hard that they honed my critical thinking skills and strategies for test taking. Dr. Morante has been very supportive, and his wisdom was always on point. Thank you for everything, Dr. Morante and PAS-NP, for helping me pass my ANCC PMHNP certification exam.
I passed! Thank you so much, Pedro Morante, for everything. For your mentorship during all of my clinical hours in my DNP program, for the PASS course that allowed me to have the confidence to excel at the PMHNP ANCC boards the very first try.
Remember your 2-2-1 rule, okay? All those questions that are difficult, sometimes they are non-scored, so don't stress about it. You should be great, and always trust the process, enjoy it. You're gonna be gonna be creating an impact to the community. Remember, it's not just to pass, but also to lead by example, to create an impact to the community. We're gonna celebrate tomorrow because you're gonna be a psych mental health nurse practitioner board certified from the Bay Area, California.
Oh my God.
Congratulations. Did you pass your board today? Wow.
The exam was very tricky. Some of the questions on your review was there. Good luck to the rest.
Yeah.
Okay, guys.
Attended our live class too in LA, right? The one in Koreatown.
Yes, I was in live class.
That was our live class. Congratulations. There you go. Ledi from California. Psych Nurse Practitioner Board. So proud of you from being my student to colleague.
Thank you, Dr. Morante.
Now, psych
you guys,
board practitioner.
Dr. Morante is really amazing. He lets you be very independent, and you're gonna use a lot, because not a lot of preceptors would allow you to like do hands-on with patients. And you know, with Dr. Morante, it's like one of the best trainings I've ever had, because I learned how to create my care plan, and then just give like, you know, he would give input if you're doing the right thing or not. So that was really good.
Hello! Wow! Welcome! So today we're gonna start a little bit earlier. As you guys all know, this is just like our community outreach, just doing the free live reviews. So unfortunately, I have to go to work tonight. But we're still gonna go through important things. This week today we're gonna talk about schizophrenia. All right, let me see. Oh, before we proceed, hi Lucretia, welcome back. Before I want to congratulate one of our students, Deepika. Congratulations for passing your ANCC and your AANP. She did both. So last week she took the AANP board exam, and today she passed her ANCC. So congratulations. It's been really wonderful, like hearing feedback from students. And let me read to you guys what she said. Let me see. 1 second. She said that. Are you? She said that the resources were very, very helpful. She said, "Thank you, Ledi. Past NP live sessions, the test banks, and a 4-hour review course really prepared me well." She was talking about her last minute preparation. That was, yeah, she also did the 4-day review course. So congratulations, Deepika, again. She used also our resources, our master fill, the past, can we show the books that we have on past NP? On our past review center. So she was using that, and it was really helpful based on her. It really guided her and helped her to prepare for the board exam. And she passed both ANCC and ANP. So she said she used all the 3 books, the Master Field Clinical Concepts, the Psychopharmacology, and Rise with Pass. When I was a student, I was using the Rise with Pass. And also, good news, we just launched a new version of our website. And if you are interested, let me look it up. So we have our new website. Someone's going to drop the link on the comment box. So right now it's actually free. Go ahead and sign up for free and get instant access to our learning resources like free daily quizzes, practice games, and it'll include this. Okay, yes, the new website. So it's right there. Right now, it's free. Go ahead and share it to everyone. This is free resources for you guys. So we're opening the doors to our beta website, and we'd love for you to be among the list to explore it. So create your free account and start checking out some of our learning resources. If you have your phone, go ahead and scan the QR code. There's like daily quizzes. And then you can also find it through the www.pastnp.com. Thank you, Lucretia. Yes, perfect. It's a really great tool. And right now it's free. Take that opportunity. Okay. You don't find this often. A lot of resources, a lot of courses will actually charge you a lot of money for this. And if you are not yet a Past Review Center subscriber, please go ahead and try it today. All right. Thank you so much to Dr. Morente and the team for coming up with this. It's a free resource. Go ahead and share it to friends, your classmates, your group mates, your schoolmates, anybody that you know who will be taking the PMHNP board exam. And I think it's also for NCLEX, right? NCLEX and FNP. If I am correct. But go ahead and check it out. All right. So today will end at around 7, so I can go ahead and go to work. And also, this coming July 25th, starting at 9 a.m., we're going to have the PMHNP last minute preparation. It's a 6-hour high yield review for ANCC and ANP board exam. It's high yield, it's 6 hours. We're gonna have breaks in between, but it's gonna be, you have to prepare yourselves to like take down notes because it's gonna be fast paced. We're gonna just focus the important things. It's gonna be with me and Dr. Morante. It's 6 hours. Go ahead, if you haven't signed up, go ahead and scan the QR code. So again, this review is free. Right now our website with daily free quizzes is free, so go ahead and subscribe. Okay, let me see. All right, so today we're going to talk about your FGA and your SGA, your first generation and second generation antipsychotics, very common medications that we use to treat patients with schizophrenia. We're going to learn about different conditions, know the differences, the receptors. Hi, Jan, welcome back. Receptor profiles, efficacy, side effects that really matter, emergency. For those who are joining us today, please go ahead and let us know where you're joining us from today and how you heard about past review. So first generation is also called the typical antipsychotics, and then the second generation is your atypical antipsychotics. Biggest difference among both of them. The first generation or the typical antipsychotics, they are very responsible for your EPS. Notorious for that. Your second generation, they are notorious or known for their what? Their metabolic side effects. So first generation, very strong D blockade. So what happens? A lot of movement problems, effective for positive symptoms, higher risk of EPS, dystonia, akathisia, Parkinsonism, and your tardive dyskinesia. It has a low risk of metabolic effects. Examples: haloperidol, chlorpromazine, fluphenazine, brifenazine, thoridazine. So be familiar with those medications. Next, the second generation or the atypical antipsychotics, the D3 5HT antagonist, D2 5HT antagonist, effective for positive and negative symptoms. So it has a lower risk of EPS, however, higher risk of metabolic effects. So I would be very careful in prescribing this to patients with diabetes. So examples are risperidone, olanzapine, quetiapine, aripiprazole, ziprasidone, lorazepam, and clozapine. So different generations, same goal, better minds, but better lives. And at the end of our review today, I'm going to share with you a new medication. So I went to a conference last weekend. It's a new medication and it's really, really great. So, okay, now let's proceed. All right. Oh. A 50-year-old man with schizophrenia and type 2 diabetes has gained 28 pounds over the past year by taking olanzapine. His psychotic symptoms are well controlled. His HbA1c has increased from 6.8% to 8.9%. Which action is the best next step? Again, which action is the best next step? Okay. A, continue olanzapine because symptom control takes priority. Letter B, add metformin and continue olanzapine without further changes. Letter C, reassess the risks and benefits of olanzapine and consider switching to an antipsychotic with a lower metabolic risk. And D, discontinue olanzapine immediately. Go ahead and type your answers in the comment box. Okay. All right. Lucretia said C. Johnny D said C. UD Cruz said C. Okay. Roger said C. All right. The answer is Candice is letter C. The answer is letter C. You got it right. So reassess the risks and benefits of olanzapine and consider switching to an antipsychotic with lower metabolic risk. Okay. It's also very important when you're prescribing these medications to educate your patients. Okay. What to expect. You know, if they are seeing these things, they have to let you know right away so you can actually manage it. So the exam tests risk benefit thinking. So the patient is stable psychiatrically, but is developing clinically significant metabolic complications. So abrupt discontinuation is inappropriate, but continuing without reassessing is also inappropriate. Okay, remember olanzapine can cause, obesity, so you have to offer another option, another alternate. Okay. So for your clinical pearl, olanzapine has a high risk for weight gain and metabolic syndrome. Before giving especially your second generation antipsychotic, you have to order what? Since it is notorious for metabolic risks, you have to make sure that this is requested as part of your laboratory test. It is a test for diabetes, your HbA1c. Okay, make sure you have your A1C levels. Question number 2. A patient taking haloperidol suddenly states, I feel like jumping out of my skin. He continuously paces the room but has no tremor or muscle rigidity. Which medication is most appropriate? A. Benztropine. B. Diphenhydramine. Letter C. Propranolol. Or letter D. Valbenazine. Go ahead and type your answers. Type in your answers. Dolores said letter C, propranolol. Same as Candice. Remember, patient said, I feel like jumping out of my skin. He continuously paces out of the room, has no tremor or muscle rigidity. What is it? That's what you call your? Okay. The answer is letter C, propranolol, because the question was describing akathisia. So it's not dystonia. Bored loves confusing, restlessness, anxiety, agitation. So the clue is can't sit still. When they can't sit still, it's most likely akathisia, all right? AKA, always keep active. So they're always running around, they're always moving, they keep on pacing, can't sit still. Okay, that's your akathisia. So when you see akathisia, the treatment is propranolol, okay? It is a non-reactive beta blocker used to treat performance anxiety, tremors, and tachycardia. I've noticed like when patients, especially like patients have like they fear doing presentations, I give them propranolol and they report they're so good. So they only take it as needed. But for akathisia, you have to give it as a maintenance. Since it is a beta blocker, what is the most important vital signs that you have to monitor when patients taking propranolol? Important vital signs that you have to monitor while the patient is in propranolol. Your what? Your blood pressure. Good job. Okay, so this table shows the common medications used to treat antipsychotic side effects. Master this, memorize this by heart. Please memorize this by heart. Common medications used to treat antipsychotic side effects. Okay, your side effects. Acute dystonia, where first-line treatment will be your benztropine, IM or PO. Okay, other options will be your diphenhydramine. Medical emergency, if airway muscles involved, treat immediately for acute dystonia. You also have to master what are the signs and symptoms of acute dystonia. Okay, drug-induced Parkinsonism, first-line treatment, also benztropine. Hello, welcome. Other option, trihexyphenidyl or amantadine, but most of the time, the board usually it will give you benztropine. So caused by dopamine blockade, avoid simply increasing the antipsychotic. You need to address it, okay? You need to address it right away. Akathisia will be your propranolol. Other options will be benzos or mirtazapine, but the board would usually ask for propranolol, okay? Benztropine is usually not very effective. Patients complain of inner restlessness. So you really have to identify what kind of side effect you are observing. Tardive dyskinesia, okay? The treatment is your VMAT2 inhibitor. It's your valbenazine. Diotetrabenazine. So VMAT2 inhibitors are first line where you have to reduce or change offending antipsychotic if possible. And then finally, an emergency, okay? Neuroleptic malignant syndrome or your NMS, all right? Stop the antipsychotic. Other options, first-line treatment, most of the time is dantrolene, bromocriptine, and admission to ICU care. So the signs and symptoms, rigidity, fever, autonomic instability, elevated CK. It is a medical emergency, all right? Neuroleptic malignant syndrome, master the keywords that describes this condition. What's the difference between the two, between serotonin symptom, hypertensive crisis, NMS, master those things, okay? So I think you can take a screenshot of this one. So you master. This is very important. This is very, very highly. I need you to master this board, this table, I mean. Next, question number 3. A 62-year-old man with schizophrenia has been treated with flufenazine for the past 10 years. During a routine follow-up visit, the PMHNP observes repetitive lip smacking, tongue protrusion, and involuntary chewing movements. The patient is unaware of these movements and reports that they do not bother him. Which intervention is the most appropriate? Letter A, initiate benztropine to reduce extrapyramidal symptoms. Letter B, continue the current medication because the patient is asymptomatic. Letter C, evaluate for tardive dyskinesia using the AIMS and consider treatment with a VMAT2 inhibitor. Letter D, increase the dose of fluphenazine to suppress the abnormal movements. Go ahead and type your answers on the comment box. So what is fluphenazine? It is a second-generation antipsychotic, okay? Your keywords will be lip smacking, tongue protrusion. During our live, I attended the PMHNP live review session in LA. So we were inside a hall. There's like, hundreds of people there. And they invited speakers. One of them actually showed us like videos. The differences, these are actual patients that participated in a study. So you can see, you can get like a visual representation of what this mobility issues look like. If you are a visual person, go to YouTube. There's a lot of videos and resources there. And then identify which one is tardive dyskinesia, which one is akathisia, which one is tardive dyskinesia, akathisia, and what else was the other one? EPS and dystonia. So, all right, okay. The answer is yes, letter C, your AIMS. So use your screening tool. AIMS is your screening tool for your tardive TD. Okay, so this patient already has tardive dyskinesia. It is a late onset hyperkinetic movement disorder caused by chronic dopamine receptor blockade. So the best next step is to perform an AIMS assessment to document severity. Consider treatment with a VMAT2 inhibitor, example, your valbenazine and deutetrabenazine. Reevaluate the need for the current antipsychotic and consider dose reduction or switching when clinically appropriate. So always accept if you see like movement problems, you have to assess them with your AIMS. Okay, AIMS health monitor tardive dyskinesia, watch for abnormal facial. Usually the keyword for tardive dyskinesia is tongue protrusion, lip smacking. Those are the common keywords that describes TD. When you see that, you'll think it's TD or your tardive dyskinesia. All right, good job, everyone. Okay, let's go to question number 4. A patient has failed adequate trials of risperidone and aripiprazole. Which medication has the strongest evidence for improving outcomes? Letter A, haloperidol. Letter B, your clozapine. Letter C, your ziprasidone. Letter D, your quetiapine. So the patient already failed adequate trials of risperidone or aripiprazole. If you were here last Friday, you would learn that I mentioned actually this condition. What is it? When you failed 2 trials, it's going to be a treatment resistant. This is already a treatment resistant schizophrenia. Okay, your answer will be, I think everyone got it right. The answer is clozapine. All right, it is very effective. After failure of 2 adequate antipsychotic trials, clozapine is the recommended treatment for treatment-resistant schizophrenia. The same concept with depression. If you have tried 2 antidepressant and still not working, it's already considered treatment-resistant depression. So same concept, depression and schizophrenia, 2 treatments, nothing's happening, patient's not improving, they are treatment-resistant. So for schizophrenia, treatment, it's a gold standard treatment for treatment-resistant schizophrenia will be clozapine. However, there should be close monitoring for your clozapine. What do you have to monitor for your clozapine? You have to monitor your ANC, okay? So clozapine is effective for treatment-resistant schizophrenia, but requires close monitoring for serious adverse effects. High reward, but also very high monitoring. You have to inform your patients if you start developing flu-like symptoms, you have to let us know right away. Okay, you have to check the ANC. Remember, if it's 8, it's too late. If it's 800, it's too late. But if it's below 1,000, you need to you have to monitor this closely. Okay, you have to treat. Question number 5. A PMHNP wants to choose an antipsychotic for a patient with Parkinson's disease, obesity, diabetes, history of medication, non-adherence. Which factor should receive the highest priority when selecting the medication? Letter A, lowest risk of hyperprolactinemia. Letter B, lowest risk of anticholinergic effects. Letter C, lowest risk of QT prolongation. And letter D, lowest risk of EPS. So the patient has Parkinson's disease, the patient also has obesity, the patient has diabetes and history of medication non-adherence. So which factor should receive the highest priority when selecting the medication? This is a very tricky. Lowest risk of hyperprolactinemia, lowest risk of anticholinergic effects, lowest risk of QT prolongation, or the lowest risk of EPS. You have to read the question right away. We made this question very tricky because I want you to use your critical thinking. Are you guys sure? You have a chance to change your answer. The patient has Parkinson's disease. So, it's lowest risk of EPS. Go back. It's on the question. This is a tricky question. The patient already has Parkinson's disease. Are you gonna give a patient a first generation antipsychotic when the patient already has movement disorders? No, you're not. So you're gonna give the patient what? Probably a second generation antipsychotic or this new medication I'm gonna show you after. Okay? Patient doesn't have any problems with the heart. So the most important part here is do not give a medication that could make the EPS or that could make Parkinsonism worse. So the STEM includes multiple comorbidities to distract you, okay? That's why I told you, read the case again. Sometimes it's just one word and it can change the entire answer. The condition most likely to be immediately worsened by the antipsychotic is Parkinson's disease because of your D2 blockade. So minimizing EPS is the highest priority. Once that requirement is met, metabolic risk and adherence strategies can be addressed. So what would be your recommendation for a patient who's having adherence problems? They discussed this on the conference too. It's here. If the patient has, they keep on relapsing because of they could not comply with their medication. Either they forget, they don't have access. The best treatment option was to provide them with a long-acting injection. A long-acting injection, you just see them like once a month, or there are now treatments you can see them like 3 months or 4 months. Okay, so remember, you have to read the question. We made this question very tricky for that reason that we want you to use your critical thinking skills. Yes, your LAIs. All right, medication, xanomeline trospium chloride. It is a new FDA-approved oral medication for schizophrenia. So it is FDA-approved for medication for schizophrenia in adults. It is the first antipsychotic approved in decades with a novel mechanism that targets cholinergic muscarinic receptors rather than the dopamine receptors. It crosses the blood-brain barrier and helps reduce schizophrenia symptoms. So it's really effective if patients are having positive symptoms too. It acts mainly in the periphery to reduce cholinergic side effects, especially GI effects. And guess what? It may not come out of the board exam because this is new, but I want you to learn these things. I'm sharing what I learned in the conference. It is the only drug approved by FDA without a black box warning. Isn't it amazing? Right? But still, you have to review warnings, precaution, contraindications, and adverse effects before prescribing. So there are titration rules when giving these medications, and at the same time, you also have to inform the patient that nauseous vomiting is expected. Once you titrate up, nausea, vomiting goes down. Only 97% of patients who went into clinical trial with this medication reported that they kept, so only 3% dropped out of the clinical trial because of nausea and vomiting, but 97% of them stayed, and about like 70 plus, I'm not sure of the, but I know that a really good amount of those patients in clinical trial asked to stay on this medication. So remember xanomeline trospium chloride, okay? It affects your muscarinic receptors. So you will be expecting what will be affected? Your like nausea and vomiting, your GI symptoms. All right. Okay. That's it for today. So before I end, we're gonna see you again on the 15th, right? I think it's the 15th. And if you haven't signed up for our last minute preparation, okay, on July 17. July 17 will be our next live. Okay, the same time. And thank you guys for joining us today. Again, take this chance to avail of the new website. So go ahead and scan the QR code. It is free. It is free. And thank you so much for your support on our community. Please share, follow, like, subscribe. Thank you so much, Addie. Thank you so much for congratulations. Congratulations for passing. Did you take the ANCC or ANP? Thank you so much. Please spread the good news and share this to everyone that you benefited from our review sessions. Thank you. Wow. Congratulations. So we have Deepika and Addie that passed their board exams. Congratulations. And if you haven't signed up on our last minute preparation, it's a 6-hour high yield review for ANCC and ANP boards. It's from July 25th from 9 a.m. to 3 p.m. And yes, Johnny D, we're gonna have the 1 hour, 4-day, 1 hour class from August 18 to 21. So once again, thank you so much for joining. Please help continue support our community and share this to everyone. Have a good night. Bye.